So I have restarted the recording, and then I'm going to welcome everyone to our Peers for Chronic Pain and Opioids workshop that we will be doing here today. So I am Adrienne Scavera. I'm the Training and Outreach Director with Mental Health and Addiction Association of Oregon, a peer-run nonprofit based out of the Portland, Oregon area. And I'm also here today with fantastic Michelle. And Michelle, if you'd like to introduce yourself for a second here.
Yes, hello, my name is Michelle Marikos. I am a peer support specialist specifically for chronic pain. I have lived with chronic pain for 20 years, and living with chronic pain, being on opioids, and lots of different pain medications, tapering off of opioids, living my life in a different way without opioids, and also working with patients, clients, providers throughout the state, throughout the country that live with chronic pain and the opioid and pain epidemics. So I work with the state of Oregon, I work with Oregon Pain Guidance and several other organizations throughout the state. So I'm so thankful to be here today with you and share this presentation. Thank you for having me.
Thank you so much, Michelle. It's always exciting to hear about all the incredible things that you're involved with as a peer and a pain specialist. So our agenda for this afternoon that we have together, the good news is the first part, we already took care of that. The networking has already happened. What we're going to be doing next is taking a look about how did we get here. So we'll be looking at a little information about the opioid crisis and some facts around that. We'll be doing an introduction to pain science and reframing the conversation about pain. Then we'll have a breakout discussion to get your thoughts and feedback about a video that we're going to be sharing. We'll be looking at what are some of the key areas for pain treatment and domains there. And then we'll be going into some background information on this continuing education unit that we are in process of developing for peers that's going to be available online for free. So we're going to be going into an overview of that, what those topics are going to be, what those modules are going to look like, and then we're going to have time for two breakout room discussions so we can hear your feedback and we can hear what your thoughts and your input are. So that is what our agenda is going to look like for today. I also wanted to let folks know if you have questions that come up, please feel free to type those into the chat box and we will be checking the chat as we are able, and we're also going to have some time available towards the end of this presentation to answer whatever questions you may have too. All right, so we did the networking, so that already happened. Moving through that slide so quickly. And then Michelle is going to share some information with us here. Thank you.
Yes, thank you so much, Adrienne. And one note that I want to say that during the networking in my group, we had a peer share that they are creating what's called a peer galaxy, and she has shared the information in the chat box for everyone for that website. So please look at that when you have a chance. And thank you so much for sharing that. So what are people living with pain missing, and why are we doing this? And what can peers do for people living with pain? I myself call them clients or also call them patients, so you'll hear me say both. What really has come to the forefront is that education about pain has been missing. Education for providers is missing on pain and pain science, but education for the patients and for the clients is actually missing. So we really are going to be looking at a lot of education about pain and about medication, education not only about opioids. You know, there's lots of different medications that are used for pain. Opioids is a large section of that and is the critical section of that, but there's lots of other education that has been missing around medication. So we really want to grasp on to medication education in general. really going into the withdrawal and tapering. What does withdrawal look like from opioids? What does withdrawal look like from other medications also, but really tapering too. And what does tapering look like? And why do we do tapering? Why is it needed? Why it may not be needed also, but really what does withdrawal and tapering look like? And really this piece around compassion and understanding. Compassion, the population of people living with chronic pain has been failed many times, and compassion and understanding is a missing component. So we really want to bring that back in using peers, and peers are always, you know, that key component in compassion and understanding, and how, you know, to move people through their pain, and also how to live differently with pain. Taming the dragon. I like to call chronic pain this dragon, and that the dragon can really flare up and you know, start fighting with you, and that we have the understanding and the ability to tame that dragon, and that peers can work with patients and clients to tame their pain dragon. Next. So how did we get here? How did this opioid crisis happen? It's not only, this is not the first opioid crisis that the US has had. This is not the first opioid crisis that the world has had. And we're going to go through a timeline in a few minutes about that briefly, just to kind of show where the opioid crisis came from. But this is also a dual crisis. It's a pain crisis also. 1 in 5 Americans now live with chronic pain. That's 20% of the population, and that's actually an underestimate of people living with chronic pain. So the average person actually lives with chronic pain for 9 years before they actually have any kind of intervention. So that people are living with chronic pain and really struggling and not being able to manage themselves for 9 years before they actually end up in a pain management program or a pain education program, or with a peer. So that's a really long time to live with chronic pain and have no understanding of what you're living with and how to live with it. So this, the pain and opioid crisis really stemmed from a lack of understanding from providers. The providers only get 6 to 8 hours of pain education with their actual medical degrees. A family practitioner will only learn very little about chronic pain and how pain works throughout the body, and that doesn't transfer to the patients as actual education for the patients themselves. So providers are not educated, the patients are not educated, and really this lack of understanding happens. So we're gonna work on that with our CEUs, so that's going to be really exciting. Next. So we're going to go through the timeline, but really this recent past of how did we get here, it was that, you know, in 1991, 88% of the medical board members believed that the extended opioid prescribing for chronic pain, chronic non-cancer pain, was unlawful and unacceptable for the medical practice. So we have had several renditions of the pendulum swinging one way or the other, and we're going to see that on this timeline coming up. Next. So I'm going to hand it over to Adrienne, and we're going to talk a little bit about facts on opioid use and kind of what that looks like.
Thank you so much, Michelle. Some really good background that you shared there about chronic and persistent pain and opioids. So we've got 2 key numbers here that really are significant to me. And the first is there are 10.3 million folks within the USA alone, just within this country, who misused prescription opioids in 2008, which is the most recent figures that were provided for the SAMHSA report. And 2 out of every 3 is the number of drug overdose deaths in that same year that involved an opioid. So we can really see from these enormous numbers that this is something that is impacting so many of us, whether it's ourselves personally or a loved one or co-workers or whomever, this is really something that it is critical that we do our best to address and support our peers around.
So I'm going to actually share my screen and bring up the actual timeline so we can go over this timeline briefly to give you some more background of how did we get here with the opioid epidemic, and really how the pain epidemic happened also.
And while Michelle is doing that screen share, I also wanted to let folks know that I uploaded the document that Michelle is sharing here into the chat. So if you're interested in looking into that more in depth, that should be available in the chat. And if there's issues with accessing that, please do just let me know. Thanks.
So what's fascinating about the opioid epidemic is that the opioid epidemic has had several renditions, but also really has followed the timeline of crises that we have gone through, starting from 1775, going into the Civil War, and really having morphine being used in the Civil War to treat veterans of the Civil War. And then also, as the Civil War kind of closed down, we had the frontier, the Wild West. And with the Wild West, there was this use of morphine, Dilaudid, lots of different opioid-based medications that were being handed out on the frontier for pain. And through that process, it became apparent to lots of frontier doctors of how opioids and opiates really did affect people. And then there was also opioid dens used in on the railroad as the railroads were coming across the West. So we had that. Then in the early 1900s, Americans, because there was no prescription use, there wasn't an actual prescription law yet, Americans were crushing opioid pills and inhaling them for pleasure, so it became more about recreation instead of actual pain management. And then in this 1914, this is a really interesting time around the Harrison Narcotics Act, that opioid prescriptions actually became mandated by the federal government. So then after that, it turned into, the providers were very aware of what opioids could do and how they ended up affecting people, and really locked down the opioid use in America. And so there was lots of stigma around the opioid use, heroin use, and the thought process around opioids. And then as kind of time evolved, it ended up going from one swing of the pendulum to the other side of the pendulum of that pain was not being taken care of. And in as we come into like the 80s and the early 90s, the American Academy of Pain came in and said, we're not treating pain enough, and that pain is the fifth vital sign. And that was really the start of our most recent pain and opioid epidemic, was in the late 1980s and early 1990s. But by the time 1998 happened, Purdue Pharma had stepped in and ended up spending $207 million on OxyContin marketing, and we'll go over that in a few minutes too. But really, that piece in time started, again, the uptake of opioid prescriptions for patients living with chronic pain. And this section of patients, you'll hear providers in provider clinics talk about legacy patients and the lost generation. And that's when this generation of patients started, was in 1998, that people living with long-term pain were on long-term opioids and still continue to be on long-term opioids. So when you hear the phrases lost generation and legacy patients, that's who that is referring to, is people living with long-term pain and on long-term opioids. So, you know, from 2010, we start from pills into the transition of heroin and really into the current rendition of the opioid epidemic and how we are currently dealing with it. So that was just a little bit of history. It's a really good timeline, and this is in the chat box. So I will go back to stop sharing my screen and go back to the slides, if we can bring the slides back up.
Thank you so much, Michelle, for that info. I've just brought the slides back up.
Okay, great. So again, we go back to the nature of the opioid problem in 2006, where we have primarily inappropriate overprescribing because providers really had this, you know, thought process that we weren't prescribing enough for chronic pain. So it ended up kind of swinging the pendulum a different way. Providers not understanding pain, I had said that before, about how little understanding providers had and still have around pain and how pain treatment should work. And then, you know, the providers and the patients didn't appreciate the risks of opioids because we had been marketed, you know, Purdue Pharma had been marketing opioids in such a way that it made it look as though, yes, we need these things for pain. We need to be able to not live with pain. You know, pain is not something we should be living with at all. So it's really very interesting. Next. So again, the pain is the fifth vital sign. We were told that we needed to be compassionate for people living with chronic pain, and that's how we were going to do that. That's when the scale of 1 to 10 through pain and our little faces, you know, the sad face, the medium face, the angry face, that's when that was created. Pain was the fifth vital sign. Next. So too many pills. Again, we just, you know, flooded the market with pills. The marketing, it was really a perfect storm of how this happened. People were already living with pain. Providers said, okay, we're going to, you know, give you more pain medication. And it really ended up, you know, kind of creating its own tornado and went from there. Next. Again, we started seeing lots of advertisements for big pharma in general. And this is how, you know, we kind of were convinced that, yes, we need all of this medication because the advertising was so well done that it really, you know, kind of pushed us into a different direction. Next. Again, Purdue Pharma, we are just, you know, kind of at the will of marketing and how marketing had worked, and you know, being convinced that this is the way you deal with pain. You deal with it with medication. And that's the only way you deal with it. Next. So really, there was no risk-benefit analysis. You know, we really never heard about the effectiveness of medication. We only heard about the effectiveness. We never heard about the risks. We never heard about the death rates, the adverse events that would happen. We never heard about dependence. We never heard about addiction. We never heard about the lifelong disability that opioids causes. We never actually, and we still do not hear around the long-term effects that opioids and that lost generation and those legacy patients, when they come off of opioids, we never hear about what actually the opioids did to those people long-term. So that's always, you know, a sticking point in my mind too, that when people come off of opioids, what happens next in their lives and in their bodies. We never really heard about the loss of family and community and how our communities were affected with opioids. Next. So also, you know, as we see the pendulum swing back and forth several times, we also need to be highly aware of really not throwing the baby out with the bathwater, that opioids do have a place, but we need to learn where that place is. We all need to learn that as a society, that, you know, we don't want to take opioids away from the people that need the opioids. We want to actually have the place and know the place for opioids and be very conscious of that place, and have a really solid understanding of that, what roles opioids play for surgeries, for cancers, for other long-term paralyzing conditions, and that some chronic conditions, opioids are very useful, but there's that but piece of chronic pain. In most scenarios, opioids are not appropriate. And so we want to really learn that line, know that line, live that line. Next. I'm going to hand it back over to Adrienne.
Thank you, Michelle. So this is a quote from a 2018 National Survey on Drug Use and Health that's done across the US annually. And I'll just read it here. Among people aged 12 and older in 2018 who misused pain relievers in the last year, the most common main reason for their last misuse of a pain reliever was to relieve physical pain. And that was 63.6% of the respondents to that question. So I think Michelle has shared some really great information and background, and the connection that we're trying to make here is that there are a lot of folks who are living with persistent pain and looking for how to feel supported, how to feel better around that pain that they are living with. And that ties us in next to our introduction to pain science. So today we're going very broad level. We're not going super in depth for these topics that we're talking about. We want to give everyone a sense. And then we're going to be talking about the continuing education unit modules that we're working on that is going to have all of this information available for our peers across Oregon who are interested in learning more about these really important and relevant topics. Then Michelle is going to talk to us a little bit about this image here.
So pain treatment, it really was ask your doctor if a pill will solve your pain, and that had been our overreaching thought process for so many years, that again, pills will take care of my pain. I don't need to be doing anything else. And in recent years, we have seen the science and seen the light around pills cannot and should not be the only thing to treat chronic pain, persistent pain, and they really aren't that effective for pain. Really, they only treat about 30% of chronic pain in the overarching realm of what other things can do. So, you know, the science is backing up, you know, we will be moving to behavioral treatments instead of medication treatments. Adrienne? So then going back to that about pain education, what patients need to understand about how pain works in the body, the different pain phenotypes. We're going to be working on that. We're going to be working really with movement, not necessarily exercise, but movement, about how to get your body moving and how to use your body in a manner that's actually helpful and not hurtful. Emotional support, of course, that's what peers do. You know, the best way we know how is emotional support, and really emotional support, emotional pain versus physical pain, and how physical pain can turn into emotional pain. And we've got, you know, our emotions, our behaviors, our thoughts, and really this the foundation of cognitive behavioral therapy, and how cognitive behavioral therapy is the #1 best used treatment for chronic pain. And really this team-based care model that we want to plug peers into the team, and that peers need to be an integrated part of the team-based care model in clinics throughout the state and hopefully throughout the nation at some point too. Next. So as we're going to be going into this video, we have created these key domains of pain, And these key domains of pain care include activity, that was that exercise movement piece, mood around emotions, what we're feeling, how we're feeling it, how to deal with our mood, sleep, you know, what happens with sleep, how sleep works, and how to get better sleep and restorative sleep. Nutrition is such a important piece of pain care, and how we can actually use nutrition the best in a really good way. Then this social aspect of how to socialize with living with chronic pain, and how to really reverse isolation. Isolation is a large part of living with chronic pain and happens very quickly, and people end up losing sight of how to get back out into the world. So, and then again, knowledge of pain, that education around pain and what pain is and how it works throughout the body. Adrienne?
Thank you, Michelle. So next, we have a video that we're going to be sharing. You might recognize two of those faces, Michelle and myself. So I'm going to go ahead and play this video. It's about 11 minutes, and it includes some really key information on understanding pain. After this video, we're going to have a couple of minutes to have a breakout discussion together, where we'll ask you, what do you see the key messages of this video as? Are there any additional messages you would add? And how would you share this information with your peers? So with that, I'm going to go ahead and get the video started. I would really appreciate it if folks would give me a thumbs up if the volume is coming through okay, so I can adjust that if not. Thank you.
So today we have with us Nora Stern, who is the chair of the Oregon State Pain Commission. Nora, thank you so much.
Sometimes when you play a video, you have to push sound on.
Thank you, Laura Rose. I swear I tested this 5 times, but you know how it is live. Those nerves catch up. What I'm going to do is I'm going to stop share, and then I'm going to reshare again just to make sure that that sound option has been enabled. Thank you all so much for your understanding while I do that. All right, there we go. And then if
For having us.
So I'm sorry, I'm going to restart the video just so we can hear it from the top. Please give me a thumbs up if you're able to hear okay.
With us Nora Stern, who is the chair of the Oregon State Pain Commission. Nora, thank you so much for having us.
Pleasure to be here. Thank you for having me. And hello, Peerpocalypse.
Mm-hmm.
I wish I was there with you at the beach, which is where we were supposed to be originally, right?
Yes, yes. Now, tell us about the Oregon State Pain Commission and who you are and what you do. We would love to know.
Great, yeah. So the Oregon State Pain Management Commission has been in place for almost 2 decades, and we're actually the only state that has a pain commission. And our purpose is to help support the public and support clinicians in creating an accurate message about pain and creating best practice pain care across the state. So one of the main things that we do is we maintain a required clinician module called Changing the Conversation About Pain, which talks about pain as a changeable experience that involves patient engagement and good communication with a pain care team and multifaceted pain treatment.
Oh, looks like it might have frozen for a second.
And I would really encourage folks to look at it, because I think it does a really nice job of highlighting some of the things that we're going to talk about today and that are available for patients to look at as well. And that's on the state site, Oregon Pain Management Commission, Changing the Conversation About Pain, and we can share that link. And then connected to that, we have a cluster of patient resources that we've been developing, and we have a new edition coming out shortly. for people living with pain that I think we're doing a better and better job of being trauma informed and having a good health literacy level. And I'll show you some excerpts from that. And those live at the Oregon Pain Guidance site. So there's provider resources and patient resources. And in the patient resources are handouts and videos. And the second edition is in there now, and the third edition will be in there very shortly within the next couple of months. And that will also include that set of links as well.
Thank you, Nora, so much for sharing that with us. The state of Oregon is so privileged to have this Oregon State Pain Commission.
And Michelle is a member, as a peer support member. So we're very happy to have that as part of our role. It's a multidisciplinary group, and peer support is a very important part of that team.
Speaking of peer support, what can you share about with peers and about understanding pain and how pain can change?
Well, this timing of the new material coming out is perfect for the Peerpocalypse conference, and I'm excited about being able to show you all some of it, and it will become the basis for the continuing education module that's being developed for peer support. Because it really was designed for patients to view and for people living with pain to view and to use as a kind of a work process with their care team. So what I'd love to do is show a little section that one of the most important things for people to understand is that we now know that pain is not just an experience that happens in the body, a result of tissue damage, but is actually a result of information from the body being connected to information at the level of the brain, and all of that has to come together to produce the pain experience. And so I think that the video section I'm going to show you does a good job of explaining that. And I want to make sure you see it because it's something that you can use, have a conversation with your own peers. Would that be okay if I showed that portion?
That would be wonderful. Thank you so much for sharing that. Let's do that now.
I will share my screen. Just a second.
And just a quick reminder,
let's talk about your pain experience. For example, have you ever had pain that lasted way beyond normal healing? Or pain that spread, moved around, feels like it got bigger? Does your pain sometimes increase with stress? When you're on vacation or having a really good time, do you find that your pain doesn't bother you as much? That's very common. Also, has pain often kept you from getting a good night's sleep? You may have had many tests that were done, but nothing seems to explain the pain that you have. Medication might help some, but doesn't completely take your pain away. You may have tried injections or surgery, but your pain returns and gets worse. And you may even have gotten the sense that people don't think your pain is real. These are very common experiences for people who struggle with chronic or persistent pain. And we now know a lot more about pain than we have in the past. For over 400 years, we misunderstood pain, and now we have a better understanding about the various causes of pain and some of the new approaches to help you deal with pain. So let me first say, your pain is very real. Let's talk about why we have pain. Pain is designed to protect us, to warn us that we need to pay attention to something that might be harming us. And we know that pain is not only the result of something that happens in the body. Pain is actually produced in the brain, which helps to explain some of pain's complexity. And it also helps us understand how pain can change. Many things can make pain worse or better. So let's look at some of the things that affect pain. So as an example, let's look at what happens when you have an injury, say to your knee. A message gets sent up to the brain that something's happened to your knee that might need your attention. But it's not actually pain yet. The brain has to take that information and make sense out of it. So actually, the brain has a big role in how much pain you experience. In addition to bodily injury, many things can influence how much pain you experience. So for example, pain and stress work together to help us respond to emergencies. Often stress is involved with pain even when it's not an emergency. Concerns, worries, and attention are also a part. Concern about an injury, about what might happen in the future, or about other things that are going on. And the focus of our attention can change pain. If we're focused on pain, we tend to feel pain more intensely. And when we're involved in something else, especially something that makes us feel good, we tend to feel pain less. How we move, how active we are, that is a big part of pain as well. If we're protecting a part of our body that hurts, bracing and guarding it, we tend to move that part less, and this creates really significant changes in the brain so that it can begin to feel like the pain has spread, moved to a new area, or can feel hard to locate. How well we understand pain can have a big impact on the pain that we feel. Pain can be very confusing, and it can be worrying and stressful to try to find solutions. This actually increases pain. If your pain has lasted for a long time, it's actually likely that more parts of your brain, more brain functions have become involved, even like memory and expectations. For example, you might remember your pain in connection with things that you've done in the past, like having pain every time you bend over at work for the past year. So this can affect your expectations. When you bend over, you expect it to hurt, and your brain begins to produce the pain response even before you bend over. We actually say nerves that fire together, wire together. The brain becomes better over time at creating pain. It actually learns pain. But the good news is that the brain can also unlearn pain, because the brain can change. The more we understand pain, the more hopeful we become about our ability to change things. We can quiet our stress. We're also quieting the emergency response system in the brain, which can decrease pain. Then we have less fear of re-injury, and we start to feel like we can get back into action. We start to do more things that we enjoy. And those parts of the brain that have been busy producing pain get busy doing other things. This is a process of changing habits, activities, feelings, and thoughts that actually changes pain itself by rewiring the brain and quieting pain. And you can do it all yourself. So,
pain video, the rest of that portion introduces the different domains that people can look at and that are wonderful conversation starters for you with your peers. But what I'd like to highlight from that, and that I think might be helpful for your breakout group, is to identify kind of the key messages, which to me are that pain is not a result of bodily injury alone, and that pain can change, that the brain learns pain and can unlearn pain. So that feels like kind of the two of the most important messages for folks to ponder, because it really reframes our thinking about what pain is and how we live with it and how we think about approaching our lives in relationship to pain.
Thank you so much, Nora. That is what a wonderful introduction to these modules and to the Pain Commission and to really the overall arching information about how pain works throughout the brain and the body. Thank you so much.
Might be one of the most important things that people can start to understand, because with the old way of thinking about pain, the idea that pain is something that lives in the body, people, I think, are often afraid to move when they feel pain with movement. because there's the sense that that must mean that they're harming themselves. But when we understand that pain is a complex process and that you can have pain that's experienced for many reasons besides tissue injury, it helps us understand that you can be sore but safe, right? So you can have pain without harm and harm without pain, which means that if you're having discomfort with movement and you know that there's nothing harmful occurring, that you have a more persistent pain kind of presentation, then that idea of being sore but safe is so helpful in understanding what you can do to get back to activity. And I think that it's explained pretty nicely in the new activity section of the patient videos, and I can show you that clip. So let me do that now, if that's okay. Great.
Yes, please do. Thank you so
All right,
much.
I will share my screen, just a moment.
In the past, you could probably do big things like hiking and swimming, and little things like going to your grandkids' soccer game. And if you pushed really hard, like hiking for 8 hours or running a marathon, you might get some pain, and that would be a warning that you'd better pay attention and change what you're doing. If you kept going, you might injure yourself. Now, with persistent pain, the level at which you'd have injury is a little lower because you haven't been moving as much. Maybe you're a little deconditioned. But look at where that new pain level is. It's really low. So all those things that you would normally do are mobilizing the emergency response system and producing pain. When the brain becomes wired for pain, we can feel pain more easily, more readily. The pain map in the brain lights up when you do even the little things like grocery shopping, washing dishes, or getting dressed. But this is important. You're not even close to injuring yourself. So you're sore, but you're safe. So how do you get back to moving and rewire the brain away from pain? The secret is to start low and go slow. So let's think about building up activity. We'll use walking as an example. Maybe you tried walking before 20 minutes and this caused you to have a flare-up that lasted for a week. And 10 minutes could cause a flare-up as well. Well, what about 5 minutes? 5 minutes may seem small, but it's a great start. So let's start here. Now, this is important. You will have pain with this activity. But remember, while you're sore, this is gentle activity and you are safe. You walk 5 minutes, 2 times a day for a week. If you do have a flare-up, you don't back off, but you do learn from that experience. Did you push too hard, not sleep well, have a lot of stress? As you stay with 5 minutes, twice a day for a week, your system becomes a little more resilient. Your pain sensitivity gets a bit better. You don't flare up as easily. And then you do 6 minutes twice a day. And gradually you increase a little at a time, and your ability goes up and up. Mm-hmm. You're still having some pain, but you're doing more. And slowly your pain will likely begin to subside as you become more active and healthy, as the information from muscles, senses, smells, sounds, balance, memory, and planning all get connected to other things besides creating pain. So, what are some steps that you can take starting?
I think one of the really great nuggets of the activity portion that conveys some of the really vital roles that peer support people can play with the clients with whom you work, right? You can see with that sore but safe, start low and go slow message, what a process this is, how much of a role a coach can play, and who better a coach than somebody with lived experience. So I'm so excited to work with MHAO and the peer support arena, because I think that bringing peer support folks into the care team around pain is going to be so helpful for clinicians to feel more supported and for patients to feel more supported. And it doesn't take really exacting clinical knowledge. It's that idea that I'm walking the path with you. And it does take having some key messages so that you're making sure that you're reinforcing the things that are really going to help on that path. But I just feel that the peer role is going to be revolutionary. So thank you for giving me a chance to show that.
Yes, thank you so much, Nora. This has been wonderful. What a wonderful introduction, and what a wonderful piece to understand what we're going to be putting together for a CEU in the future, and that peers can actually help their clients and that clients can actually move through their pain. Thank you so much, Nora. This has been wonderful.
Yeah, glad to do it. My pleasure.
Nora, in the understanding.
We're not going to watch it twice. Don't worry. So now Michelle's going to share a little bit of information about peer support and moving beyond pain. I really wish we had an extra 30 minutes together because I think this is an incredible group and the discussions have really been vibrant, but we're going to be pretty quick because we've got about 20 minutes left together. So Michelle's going to share a little bit more about the peer support piece, and then we're going to talk about that continuing education unit. Thank you.
So we are so excited to have peer support, a CEU for moving beyond pain and education about opioids, educating. We had talked in my breakout group about hope and about how hope has really been something that has been missing for this population. So it's melding together the education, the hope, and the support. And, you know, we're so privileged to live in Oregon that Oregon is one of the first states to have this type of program for peers with pain. And we're just really looking forward to building this network and building peers into integrated pain, integrated pain treatment.
Yeah, thank you so much, Michelle. So now we're going to talk about this continuing education unit. I feel like we've really built up to this and been saying, oh, CEU, we're going to talk about it. Now we're here. We're going to talk about it. So here's a little bit about the background and basics. So this was initially funded this year, not too long ago, by the Injury and Violence Prevention Program at the Oregon Health Authority. They saw and we saw a need to share information with our peer workforce, with the excellent peer supporters and recovery mentors across the state who are doing such key work and playing such integral roles within recovery communities. And so OHA contracted with MHAO as a peer-run organization. And we've done a lot of peer trainings. You know, we do Peer Apocalypse. We're all here right now. And we also wanted to connect with subject matter experts, key folks like Michelle, who is a pain specialist as a peer, like Nora, who we just saw talking on those videos, and a couple of other folks as well. So in terms of a broad level overview, this continuing education unit is going to be free, it's going to be online, and it's going to be specially created for us as members of the peer support and recovery mentor workforce. So it's going to include information on understanding pain, reframing the conversation on pain, and how to effectively support others who may be living with pain. Modules are going to have an overview of the topic, brief video clips, sort of similar to the ones that we had just seen, and connections on how to use this information in peer support and what some of those key messages are, sort of conversation starters, if you will. So with how this is planned, there is a 1-hour online course that already exists. That's called Changing the Conversation About Pain. Pain care is everyone's job. And that was developed through the Oregon Pain Management Commission and is available on the Oregon Pain Guidance website. And we're going to get that link. I'm going to enter that link in the chat in a little bit in case anybody wants to check out the resources and information that has been available on that site, because they're doing so much work about pain education and even advocacy related to that. So that's an hour-long prerequisite so we can all come into these peer support modules with the basic understanding of pain science and of these key topics as it relates to supporting folks around pain. So there are a whole bunch of different proposed topics. So these modules will be pretty short. We're thinking are between 15 to 30 minutes, probably more around the 15. So we're not giving folks too much information and also not asking too much of your time. So the first would be that state pain module prereq. And then covering all of those really key topics like understanding pain, sleep and pain, mood, stress, trauma and pain, activity. We saw a little bit of the pacing module, nutrition, social, flare-ups, understanding opioids and other medications, and then that final micro module being the role of the peer in pain care. So there's a lot that we're hoping to accomplish and a lot that we're hoping to include within these mini modules for this peer continuing education unit. So I want to just briefly share the structure, and then we're going to ask for your thoughts and feedback. So the thought is we'll have some broad level information on the topic so we can all have that knowledge base. Then there will be tools and modeling with a core video clip on whatever that topic is, sleep, for example. Include some key messaging for working with people who live with persistent pain, key phrasing for peer supports, and then there'll also be mini little knowledge check quizzes that are a part of the continuing education unit as well. And I see a couple chats are coming through, so I'm going to check those. Very excited. This is great. That's great news. Yay. I love the positivity. That's really fantastic to hear. And so now we're interested in the feedback that all of you have around this. So we've got about 15 minutes left. So we're going to use a little bit under 15 minutes to just get your thoughts and your feedback about these many different modules that we're proposing to create to have this information available for those of us in peer support. So the couple key questions we're interested in, your feedback generally, if there's anything you feel we're missing, and then if there's anything that's important to you when learning online. So I'm going to go ahead and set up our breakout rooms once again. So you should see a little invitation coming up that's inviting you into your breakout room. All right, welcome back, folks. I see people starting to rejoin us. Excellent. Thank you. I hope that was a useful time to give a little bit of feedback. I also want to acknowledge that it went by really quickly. So I invite everyone and anyone to reach out via email, or if you'd like to have a phone call, we can do that too. Let me know what your thoughts are, what your feedback is, because I think together we're really going to come up with the most effective way to share this information and make sure that peers across the state have access to these online modules. So I really encourage anybody who's interested to reach out. We can keep this conversation going even as we come up against these time boundaries for the Peer Apocalypse workshop today. So I'm going to go ahead and just really briefly share the next steps, developing content, getting all of that together, making sure that feedback is incorporated throughout that. And then the final step, it looks so easy because it's just 3 little blocks, right? I'm like, woo, is creating and publishing that online CEU. I see a comment to put our emails in the chat. I'm going to go ahead and do that right now. My email is ascavera@mhaoforegon.org, and I've just entered that in the chat if anybody wants to follow up, has any questions or comments after this. We've also got our email available on these slides. These slides and the videos within them will be available. They will be up on the Peer Apocalypse website. It may take a week or 2 for them to get posted up there, but if you're interested in re-looking at this information or sharing this with anyone, I encourage you to check out the Peer Apocalypse website. But as we start to close here, I just want to say thank you all so much for your interest in this really important work, and just thank you for your time and your engagement and the thoughts and the feedback that you've shared today. And also a big thank you to the incredible Michelle as well, who is so knowledgeable and just a great presenter. So thank you all so much for being here with us today. All right, so Michelle, do you have any closing comments or anything you'd like to share before we wrap up here?
All of the feedback has been so wonderful, and I am so encouraged, and I'm so excited to be part of this process, and that we are, going to do this, and we're going to get the CEU out to everyone. And I'm really excited. We've been waiting for a long time. I've been working on trying to get this type of thing out into the world for about 8 years now. So it's just really exciting that we are in the forefront and that we're going to see this actually happen. And I'm so excited. And I'm so excited to have all of you involved. And please email me or reach out if you have anything, any kind of comments or questions or need anything. Yes, this is so wonderful.
Thank you all so much. I just said it and I just typed it in the chat too. I can be kind of a redundant person. All right, I hope everyone has an excellent rest of your day and rest of your Peer Apocalypse. And I hope to see some of you in these virtual rooms either today or tomorrow. And thank you all so much for your engagement and being here today. Bye-bye. I'm going to close the workshop room at this point. Thank you all.